Good morning, everybody. So today I wanted to discuss a topic that I'm pretty sure everybody sees quite a bit, probably on a daily basis. Next slide. I have nothing to disclose. Next slide. We're going to focus on reviewing the diagnostic criteria for PCOS, the evaluation and the medical care, and again, only primarily making the distinction between adolescent and adult. So the pediatric, the early stages of the disease that then later on continues when you're an adult. And then I selected two cases at the end to go over that are rare cases, but it kind of shows you or gives you an idea of things that I want you to kind of become familiar to look into. Next slide. So PCOS has been around since a while. So it was first described by Stein and Leventhal in the 1930s, and is a common heterogeneous disorder that affects a good proportion of females in reproductive age, up to 15%. And the etiology of it is not fully understood, but is starting to be kind of more unveiled as time goes by. But we do know that PCOS is a multi-system disorder that involves not just the ovary. Next slide. So this image kind of tries to portray that. So originally thought to be a primary disease of the ovary. Now we know that in patients with PCOS, they have a hypothalamic and later pituitary dysregulation of LH and FSH secretion, leading to a higher tone of LH. And what that does is when it goes to the ovary, and I'll teach you more about that in future slides, that excess of LH stimulates or favor androgen production at the level of the ovary, and also causes arrest of the follicular maturation. And with that, of course, we have the feature of androgen excess and polycystic ovary morphology. In addition to that, so we talk about the hypothalamus pituitary, the ovary. Patients with PCOS have insulin resistance, and that insulin resistance is tissue specific, so it varies depending on the side of the body that we are talking about. So that resistance happens at the level of the muscle, at the level of the fat, and in the liver. And as a result of that, the pancreas secretes more insulin. But other tissues, including the skin and the ovaries, are sensitive to insulin, and we will learn about how insulin stimulates androgens in the ovary. So you can see how complex is this, the mechanism behind this problem. Next slide. So we use the Rotor, of course, there's 3 classifications for PCOS, and the one more accepted is the Rotterdam criteria. But here's where we have the problem with adolescents when we use this criteria, is that from this talk, I want you to kind of stay away of thinking that you need an ultrasound, an ovarian ultrasound, to make the diagnosis of PCOS, so the lesson number 1. So we're going to focus on thinking on this condition for our patient population by thinking only on the presence of oligo or anovulation and the clinical and or biochemical hyperandrogenism. And yes, PCOM is part of the criteria, but we are not going to think about that for now. And the other key lesson is that this is a diagnosis of exclusion. So even though it's going to be the condition that you see the most leading to hyperandrogenism, it still remains a diagnosis of exclusion. So you're obligated to think about other things that can lead to this problem. And with the full use of the Rotterdam criteria, you can distinguish 4 different distinct phenotypes. But as we mentioned, because in adolescents, we're only going to use the menstrual dysregulation and the hyperandrogenism, we only can say use kind of the classic phenotype. Next slide. Next slide. And so we're going to go over a series of questions to kind of learn about our topic today. So what are the appropriate diagnostic criteria for PCOS in adolescent girls? Well, we have a problem because the features of PCOS really overlap with the normal process of puberty. So we all know that adolescent girls have irregular menses, they have acne, they have mildly elevated androgen concentration, and they have multifollicular ovaries on ultrasound. And so how do we make the diagnosis of this condition? Next slide. And I wanted to kind of put this slide relatively early in the presentation because this is one important thing we have to keep in mind. This is a complex disease that most of these patients have comorbidities associated, regardless if they're lean, so not just the ones that are obese. And we have to think about this early on. So yes, they have irregular menses, they can have diminished fertility, they can have hirsutism. Many of them have either impaired glucose tolerance, insulin resistance, hyperinsulinism, or type 2 diabetes in the more severe cases. They have dyslipidemia, hypertension. Because of the lack of their bleeding, that endometrium stays inside their body for long term, and so they can have endometrial cancer. They're prone to be obese. Because of the metabolic derangement, they can have fat in their liver, they can have a sleep apnea. And the last 2 points are really, really important. These patients really can have depression, they have impaired quality of life. These features that they're undergoing really affect them. And we do know how important it is for adolescents when they have acne and they have hair, they really stress about that. And the last point of eating disorder or disorder eating is something that I also wanted to take home as a message. Especially when we go over how we treat this condition, we're going to be talking to adolescents about potentially weight loss if they're overweight. And this is a population that can go into problems with their eating and exaggerated loss of weight or abnormal things that they would do to lose weight. So we have to be very sensitive about that. Next slide. So what are the criteria for clinical evidence of hyperandrogenism in an adolescent girl? Well, the first thing that we have to think about, and we don't have like a clinical criteria for adolescents, but we have to think about clinical hyperandrogenism when we see hirsutism, we'll talk about that, and severe inflammatory acne. Next slide. So what is hirsutism? And this is another thing I want to take a second to discuss, because in the endocrine clinic, we have a lot of referrals for hirsutism or even pubic hair development, and you have to kind of understand the difference between the things. So hirsutism is when hair grows in a female's in a male pattern distribution, so those typical areas. And it's very different from hypertrichosis, which is this generalized increased body hair that is very thin, that we usually will see it in the forearms on the lower legs. So that is not hirsutism. And the result of that comes because that interaction between the androgens that float in the blood, the local androgens at the tissue level, and a unique response to the hair follicle to these androgens that are in the hormonal milieu. And also note that even severe hirsutism does not necessarily correlate with higher levels of androgens. So you can still have hirsutism that has normal androgen levels, so idiopathic, and you can have severe levels of hyperandrogenism in the blood without hirsutism. So keep that in mind. Next slide. And so we use the modified Ferryman-Galway score. It's modified because it started with 11 areas of the body that were used, and now we use 9. We use the upper lip, the chin, the chest, the periumbilical area, the upper part of the arm, the upper part of the legs, the upper back, and the lower back. And we use the grading of 1 to 4, 1 being no hair and 4 being very severe. But remains being a subjective, it has that subjective nature that we have to kind of do our own assessment of what we think, why 3 and not 4, and all of that, right? And there are different cutoffs among racial and ethnic groups, although we use more than 8 to 15 as mild hirsutism, 15 to 24 as moderate, more than 24 severe. There are certain backgrounds, especially different backgrounds that will use a lower cutoff, especially Asian population. And when we talk about hirsutism, again, those are terminal hairs. Terminal hair is the term used for hair that has the ability to be stimulated by these androgens, right? And so it tends to be long, it tends to be coarse, and it has different shapes. And also, you have to ask the patient if they have done any cosmetic treatment that can alter kind of our grading system. Next slide. And the acne, again, very common in adolescents. We don't have a tool to give a stratification, but severe acne is the one that you're usually going to have difficulty treating in your clinic. So the ones that you're thinking of referring to a dermatologist, a lot of inflammatory acne, that is less common in adolescents, and that kind of make you think about elevated levels of androgens. Next slide. And so what is the criteria for evidence of biochemical hyperandrogenism in the adolescent girl? Well, let me tell you where these androgens come from. So in the figure on the left, you have the double system in the ovary that is the Tika cell and the granulosa cells that are the ones that produce the sexual hormones that we need. And that production of estrogen and androgens are primarily used within the ovary. And so you have the Tika cell, the outer layer, which is stimulated by a latent insulin that produces primarily androstenedione that diffuses into the granulosa cell, and the granulosa cell aromatizes those androgens into the female hormones under the effect of FSH. And then in the adrenal glands, we have in the cortex of the adrenal gland 3 layers. So the zona reticular is the one on the pink, is the one in charge of producing androgens that are going to be used in our hair, in our libido, all of those things that we need androgens kind of floating around our body. And so we produce the ATA sulfate, and androstenedione. Next slide. So which androgen are we going to measure if we don't see obvious clinical features of hyperandrogenism? So we measure testosterone. So testosterone is the major circulating androgen, and we have most of it circulates bound to sex hormone binding globulin and a little portion to albumin. And then we have, like any hormone, a small portion that floats free, and that of course is the bioactive hormone. And those are the two that we will be measuring. But it depends what you have on hand. So this is the one hormone that you want to know what lab you're working with, like what methodology they're using. Because it makes a world of a difference when we are measuring androgens in females who are supposed to have lower levels. And so for the lower level detection, we need a better quality test. So that's where the gas chromatography or liquid chromatography comes so handy. But again, not all the laboratories have that on hand. And then there's no cutoffs recommended. So you are going to be using, again, going back and forth between adult and adolescent, you're going to be using the cutoff that is that your lab provides for these tests, and that's usually for adults, and that will be okay. And usually a total testosterone higher than 55 or 60 will be considered abnormal in most assays. But the other key point I want you to take home is that this is a persistent elevation. It's not that one and only, and I'm done. Because these hormones vary through the menstrual cycle and the time of the day, so you want to evaluate persistence of a problem to make this diagnosis. And in patients that already come to you on combined oral contraceptive pills, that you cannot measure this because they're going to cross-react with the assay. So you need to have about 3 months period washout before testing. And other androgens elevations that we measurements that we do, including androstenedione, the HEA, 17-hydroxyprogesterone, which we will talk about, are less useful for the diagnosis of PCOS, but are used for the differential diagnosis of these conditions. So we will talk about them. Next slide. So what are the criteria for evidence of oligonovulation in adolescents? So the median age at menarche remains unchanged despite the movement of early breast development that we are all seeing. So remains 12 to 13. Many adolescent girls, as we know, have irregular menstrual cycles, and the ovulatory dysfunction can still occur even if they're menstruating or bleeding every 28 days. Next slide. So this is a slide that I want you to remember. Like I always teach this to our residents. So how do we define irregular menstrual cycles? Well, you have to define that according to years post-menarche, and there is no way around that. It's so complex for the brain and the ovary to learn to communicate that the first things we see are just an attempt of a conversation. So even if we see a bleeding, most of those bleedings are going to be not truly functional or ovulatory. And so it's normal within the first year post-menarche to see bleedings that are, all over the map. And then when we pass the first year post-menarche up to 3, we can remember to and teach our patients to say, well, from day 1 to next day 1 is okay if that falls between 21 to 45 days. After 3 years, then that distance shortens from 21 to 35 days, and you do have to have at least 8 cycles a year. And then more than 90 days, so 3 months without a menstrual cycle after the first year will be considered abnormal. And the definition of primary amenorrhea is when you haven't achieved menstrual cycles by the age of 15 or 3 years post-thelarchy. And I do have to say on this side that there is a little bit of variation on this. So the girls that we have that have started menses at 10 versus the ones that started menarche at 15. The younger you are when you start bleeding, the brain and that ovary learn to communicate faster. So there's a little bit of variations between, versus if you see your patients that, like their moms, starting menses at 15, they sometimes take a long time to really have a normal frequency and a coordinated conversation and ovulation. Next slide. So the challenge for us is that how do I differentiate physiologic adolescent and ovulation from those with an ovulatory dysfunction? Well, the key is in the persistent, as we talk about the persistent of the androgen elevation, persistent of oligomenorrhea. So that is kind of the key. So the key is that these patients need to be followed. You don't need to make the diagnosis today. These are going to be your patients that you're going to follow as a general pediatrician over the years, and you're going to monitor that and teach your patient to what are the things they should be looking. So when they're coming to see you, they can say, okay, tell me about how your periods. I usually give them a menstrual cycle tracker, so we sit down together and look to see if things are getting better or getting worse. Next slide. And so this is the thing that I want you to think the least, but I wanted to teach you about this. This may change in 5 years from now. Because this is an area that is being evaluated as to what is the normal number of follicles and the normal growth and regression of the size of the ovary in adolescents. So there's a particular study looking at that now. So when we talk about that conversation between the pituitary and the ovary, that exacerbated LH predisposition that these patients have lead to an increase in androgen production and an arrest in very early stages of maturation of the follicle, this pre-antral and early antral follicle. In addition to that, those arrested follicles produce anti-Müllerian hormone, which is a hormone that we discuss a lot in the literature of PCOS. What that does, the higher the level of anti-Müllerian hormone, it inhibits the FSH, the hormones that aromatize androgens into estrogens. And so all in all leads to a state of follicular arrest and hyperandrogenism. Next slide. So ultrasound should not be used for the diagnosis of PCOS in those with a gynecologic age of less than 8, if you remember that. So meaning, say, if you start your menses at 12, you're not going to be using this tool for the purpose of PCOS until you're like 20. So have it at the bottom of the differential of your tools. And a lot of healthy girls have PCOM by the criteria that is used for adults. And we know that having that doesn't necessarily indicate that these patients will have PCOS when they're adults. So we do not use it as a tool. Now, if we have somebody who is 21, is already sexually active, is preferred to use a transvaginal approach, and we will be looking to a number of more than 20 follicles and an ovarian volume of more than 10. Next slide. We talk about anti-Müllerian hormone, a hormone that is coming to a discussion a lot, but we're not there yet. The essays, you have to understand hormones are very difficult things to measure and very different to measure creatinine and BUN, and our CBC requires very difficult technology that is only concentrated in some labs. So a lot of the things even that we do at Seattle Children get sent to Mayo Clinic for processing. So anti-Müllerian hormone has a lot of different results. So it's not used for the purpose of detecting polycystic ovarian morphology in adolescent girls. But it's produced, we talk about, from those small ovarian antral follicles. It declines after the follicle is selected, selected to continue maturation. And it's used primarily as a tool to evaluate ovarian reserve. But we yet don't use it as a surrogate for PCOM. Next slide. So what diagnostic procedures are appropriate in adolescents to exclude other causes of hyperandrogenism and amenorrhea? So these are the conditions that I want you to think. We talk about ruling out other conditions before we label a patient. Like, just hold your horses, don't label or diagnose it until you think about this. The most common imitator of PCOS is late onset congenital adrenal hyperplasia, the kids that have mild dysfunction that are not detected by newborn screen. And so we'll talk about how we test for that. Of course, thyroid dysfunction, hyperprolactinemia, ovarian and adrenal androgen secreting tumors, which is very rare, but it does exist, and Cushing, which is also very rare in adolescents. Next slide. And so these are the tests that you will be thinking on doing. Again, a lot of the things, including thyroid disease, is very obvious on clinical grounds, but some are a little bit more subtle, right? So the laboratories that you will be thinking on doing is the 17-hydroxyprogesterone, again, looking for late onset congenital adrenal hyperplasia, and it's best to do it in the morning when these in general, hormones are at their worst behavior, and you're looking at values higher than 200 milligram per deciliter. When you have that, that's a patient we will see, because the next step after that is doing a stimulation test to kind of unmask any potential partial blockage. And then we talk about doing total and free testosterone. The sex hormone binding globulin is primarily done if you don't have in your local lab an assay that can run the free testosterone. The free testosterone best methodology is by equilibrium dialysis. And so we talk about LC-MS for total testosterone and free testosterone by equilibrium dialysis. If you don't have that, your lab, even sometimes you order that. It happens to me when I do my clinic here. I order the test and it comes back something very different than what I order, and I have to make the best out of it. But kind of like you will think that patients with PCOS, we talk about having hyperinsulinism. The excess of insulin decreases your sex hormone binding globulin. So you will be finding in these patients a low level of sex hormone binding globulin, hence that excess free bioavailable testosterone. And then the androstenedione dye and the DHEA-sulfate are more looking for a more adrenal disease. And the thyroid function test, the prolactin, and the latent FSH. Next slide. So what is the role of insulin-resistant hyperinsulinemia in the diagnosis of PCOS in adolescents? So we talk about the insulin resistance in this condition being tissue-specific and leaving the skin. That's why we see the acanthosis nigricans in our patients, leaving the ovary, being able to respond to that excess of androgens and causing the high levels of androgen. And so also insulin, we talk about decreases sex hormone binding globulin. So all in all, puts more wood to the fire. And the insulin resistance of PCOS is inherited to the pathophysiology of the disease. So it's part of what is happening to the patient. And it has not necessarily something to do with their obesity, although they can be obese. And of course, that will make things worse. Next slide. And the other thing I want you to think is, what are the prenatal factors that are relevant for PCOS? And the most important one being babies that are born growth restricted, but that have rapid weight gain, which is something we all see all the time. Those patients, we see them first in the clinic with precocious adrenarche, so pubic hair development before the age of 8. And many of those little girls that gain a lot of weight, we know that they most likely will have PCOS. So we do already, when we see them for precocious adrenarche, start to introduce the idea, especially again if they've been very small at birth, but then gain a lot of weight rapidly. Next slide. So when we think about PCOS, is we have to kind of balance the good and the bad. Yes, making a diagnosis at the adolescent age has the opportunity of early on starting to have a communication with the child, teach her, and introduce an intervention. But that balance also has to come because we are using a term that for the most part causes a lot of anxiety. Families go and look, we know, they Google, they think they will never be able to have kids, and I don't know if you have seen it, but I have had adolescents that have cried. They come with a preconception. Many of them have their mothers or their aunts to have PCOS, so they know they have to go through fertility treatments. So we kind of have to get to know the situation before we say, well, I think you have PCOS. So just, get to know the patient before using that term loosely. That will be the idea. But overall, the interventions that we use are safe to use. So we have to balance these two things. Next slide. So then we move on to treatment. And of course, one of the things I practice with the patients is like, what is the symptom that bother you the most? And that's really important to always ask. Many of them, you will be surprised, adolescents do not like to have their periods, and sometimes they get mad when they start bleeding. So like, what did you do to me? So you have to tell them that, periods, as much as we don't like them, they're there for a reason and they need to be there, and you explain them why. But then many of them will say, my acne really bothers me, or my hair. So you have to gather why is the patient here? What bothers her the most? Because we know metabolically these patients have a long road to go, and the hair it's not going to kill you. This is not a problem that it will cause a lot of problems to the patient later on. But all these other comorbidities that we discuss are, so we kind of have to put what we think medically is important to what the patient is perceiving as the most important problem right now. And so if the patient is obese, we kind of we start to introduce little by little the discussion about healthy lifestyle. And we know that that's the main intervention for patients that are obese or overweight. But again, knowing that these are adolescents already prompt to have eating problems. And we certainly have seen and have precipitated anorexia in patients where this was kind of discussed not in the right way, and it can again precipitate a big problem. Remember, when they're coming, we're congratulating them for their weight loss, and that kind of feed in an adolescent mind that already has a pre-existing problem. And then the thing that we're going to talk about the hair, I personally always discuss with the patients that it's kind of sometimes think about the hair as something that you primarily want to treat it from the outside before giving a medication that alters your entire hormonal milieu and body. So we teach them a lot about the different techniques that they can use, from simple things from waxing to bleaching to the topical eflornithine cream these are things, by the way, except the things you can do at home. The creams and the cosmetic treatments are out of pocket for families, and that we know that is not a reality for everybody. The waxing will be the cheapest thing, right? Especially if it's done at home. And all of these, like the eflornithine cream or the electrolysis or the laser, requires us to send them somewhere. They have to pay, and they have to continue doing it, so it doesn't end just with one session or two. Next slide. And then we move to the medical interventions. The first one being the combined oral contraceptive pills. That will be your first option, and it can improve the condition at different levels, but it does require time. The combined oral contraceptive pills have a combination of estrogen and progestin. The estrogen that we're selecting should have more towards the higher end amount, because again, we're trying to change that hormonal milieu. And the progestin, we want to use one that has a low androgenic level. So the one, my favorite is the orthocycline, the norgestimate. The third generation progestins have more of a VTE risk, and they also can cause changes on the electrolytes, so we have to kind of keep that in mind. And regardless, because we're going to use the venous thromboembolism risk increases the higher the level, the estrogen, and the kind of the third generation progestins. So we want to ask of any family history or personal history of ET or thrombophilia before we start the treatment. Next slide. And then we use metformin, which kind of helps with that part of insulin sensitivity that we previously discussed. But that's primarily used for patients with insulin-resistant as background. And the anti-androgens that you will see a lot, especially from our colleagues from dermatologists, spironolactone, certainly not is used and is effective. It takes time. It starts with doses of 25 milligrams up to 200. I personally don't use it, but I have my patients co-manage with dermatology that is their first line of intervention, certainly not mine. The reason why is because, again, when you use spironolactone, it's teratogenic. It has to be used with a highly effective combined oral contraceptive pill, which is going to be my first line of intervention. So kind of I take one step at a time before polymedicating the patient. Next slide. And so the key points is that adult criteria is not applicable for adolescent girls. It's a diagnosis of exclusion, and we talk about the things to think about. The diagnosis of PCOS should be primarily based on the clinical and or biochemical signs of hyperandrogenism as well as the irregular menses. And it should not be given to a patient within the first 2 years post-menarche. Again, we talk about why. And if the patient over time in our follow-up does not fully fulfill that criteria, but it looks like a patient, we have rolled other things, is not getting better, but you can use the term at risk for PCOS. And regardless of giving that diagnosis or label it as at risk for PCOS, still the interventions of the comorbidities will take place. So we don't need to wait to treat an obese child, a child with insulin resistance, until we label it as PCOS. That's the message I want to leave you with. And know that, of course, as we discussed, all these features overlap with the normal physiology of the adolescent. Next slide. And so the polycystic ovary morphology is not a criteria, although it can be seen, but can also be seen in healthy girls. Obesity, insulin-resistant hyperinsulinemia is going to be a common comorbidity of this condition. And as we discussed, we can treat regardless of a definite diagnosis, focusing on the problems that the patient has. Next slide. And so, I have a lot of time. So let's walk through these two cases. And again, these are not probably things that you will see every day, but I wanted to kind of leave you with the lesson learned. So the first patient, she presented to me when she was 13 years and 9 months. She was evaluated by the pediatrician for the possibility of PCOS. When I gather the history, the family says, we're really concerned about her rapid weight gain, right? And she had no changes to her physical activity or food intake. Her gynecologic history started with thelarchy at the age of 9, menarche many years after thelarchy at 13 years and 7 months, and she had only had so far one menstrual cycle. She had oily skin and acne, no hirsutism, and she had frequent folliculitis and sinusitis. She was complaining of being tired and having a decreased muscle strength. So much so that in one of our old clinics where we used to practice rehab medicine was next to where we sit, and the rehab physician, who we know each other, came and said, oh, you're seeing my patient, by the way. She used to be an athlete, and now, I don't know what's happening with her, but her muscle strength is not the same, and I cannot make it to improve. Next slide. So both parents were obese, and the mean parental height of these parents is 161 centimeters, so that fell on the 25th to the 50th percentile. And she had 2 healthy brothers that were lean. Actually, the youngest was also my patient for another problem later on. She had no recent changes on her health, on her diet, medication, physical activity to account for what I'm going to show you on the growth chart. She continues doing physical activity 4 times a week, very bright young girl. Next slide. And on the physical exam, she was slightly hypertensive. She had proportionate obesity. Her abdomen was obese. She had breast tender stage 4 with pubic hair tender stage 4 and no clitoromegaly. She had facial and upper thorax acne and oily skin, a stria on her abdomen, arms that were dark pink. And there was a slight skin hyperpigmentation that became very obvious after we diagnosed her and provided intervention. That's why I put it as a question mark, because I didn't realize how pigmented she was then. She got acanthosis nigricans on the back of the neck and armpit and no hirsutism. And on my exam, she had no proximal muscle, normal proximal muscle strength. And her skeletal exam was normal. On this, I was looking for stigmata that can explain why her short stature for family, so she did not look to have Turner syndrome or other conditions. Next slide. So on this one, you can see I couldn't remove the surgery. So you would think, what does she have that she had to go through surgery? But look at the weight chart on the left. The problem started somewhere when she was 9 with a dramatic weight gain, right? And you can tell why the family was really worried. And then always in parallel, we look at the height. And the height decline started about a year after the weight started to increase. So by the time I met her, I think she was here, somewhere in here in the middle. I might be missing a dot. So the bone age was 13, so she still had about a year of time for growth. Bone age of 14 is when girls stop growing. The mid-parental height is 160 centimeters in here, and the patient was short, was like quite far from where she needed it to be, considering her skeletal age was 13. Next slide. I think the next slide shows you, this is the BMI again. So dramatic change to the BMI and with change after her intervention. Next slide. This one, I'm not gonna make you go through all of this, but the patient ended up being, so when I saw that growth chart, because for me as an endocrinologist, there is a say that we learned very early on that when your weight goes up and your height goes down, that's an endocrinopathy until proven otherwise. So the common ones we see are Cushing, our growth hormone deficiency, our hypothyroidism. Those three behave that way. So of course, we're assessing a patient for all these symptoms. Cushing is very much top on the list. Although we have done all the other things we mentioned to rule other conditions, we did Cushing testing. And Cushing testing is not something I want you to learn to do. I think if you are worried about Cushing, is enough to have the patient come our way. It's one of the conditions that is the most difficult to assess, and because they need multiple, what we call tiers of testing. So being the last one, the image. And so we do first tier testing where we do multiple samples, either nighttime salivary cortisols, multiple of them, because when we kind of going back one step, when we have Cushing, you have Cushing that comes from the pituitary gland or from the adrenal gland, or ectopic, which is very rare in pediatric. And so the most common Cushing form that we will see at this age group is a pituitary adenoma. So those pituitary adenomas secrete cortisol in a very erratic way. So it might be silent for today and then become really active for another day. And so the reason behind testing multiple kind of methodologies is to capture where it can be high. And so again, it's quite labor intense and expensive. So you have to be relatively convinced to go and pursue this testing in a patient. So this is not something that you would do in all your patients with hyperandrogenism, right? If you have the luxury of having that growth chart, then for sure you have to pursue that testing. Sure enough, she had half of her tests abnormal in the first tier test, then the second tier test, we repeated some of them. Again, some of them came back abnormal, and then we move on to do image. And so again, going back to testing, that can be from midnight salivary cortisol to 24-hour free cortisol in the urine to the dexamethasone suppression test. So that's a little bit complex to do. When I thought I have enough, I put the patient to have a brain MRI. And the brain MRI, the lesion was so small, And we're very lucky to have a neurosurgeon that we share between Seattle Children's Endocrinology and the Pituitary Clinic at the UW, who has expertise in pituitary surgery, and that is operated through the nose. So he's very familiar to looking at these images. And with that image alone, he says, that's an adenoma, we will go and take it out. And the reason why I say that, because in adults, it's not as simple. Sometimes other testings need to take place to measure where this cortisol is coming from or ECTH is coming from. So we were very lucky that with that one image, we have enough to pursue. She went to have the adenoma removed from her nose. The pituitary is tiny, tiny, like the nail of your pinky. And so was able to be removed. She continued to have normal function of her pituitary after that, and she graduated as a healthy lady when she was 21 or 22 from our hospital. So that's a success story. And next slide. And this second patient also kind of shows you where we emphasize about the persistent and taking your time and reassessing your patient before making a diagnosis. She came to us when she was 18. She entered Seattle Children through the Adolescent Medicine Clinic. She was transferring from Nevada to Washington, where she was living now, and she tell us she was diagnosed with PCOS at the age of 11. It's already a red flag, right? She's too young. But let's listen about the gynecologic history. She started thelarchy at 9, adrenarchy at 10, and menarchy at 11. Could she be diagnosed with PCOS at 11 if she just, no. So we talk about that. So that's already a big red flag. And she had subsequent oligomenorrhea. She had one period and then none again, and she was started on oral contraceptive pills. And she recalls having hirsutism with hair on face, chest, and back, and she shaves frequently. She has acne on chest, shoulder, and back, so quite severe, and occasional right lower quadrant pain. She was treated from the age of 11 to 17 with combined oral contraceptive pills, spironolactone or metformin. When she came to us in that transfer from one state to the next and reestablishing medical care, she ran out of all the prescriptions. She came with nothing for at least a year, and her symptoms were terrible. Next slide. And so we were like, this is perfect. Let's reassess what this patient really has. Again, that's a kind of like something we always do in endocrinology. It has to be somebody we really trust to carry on the diagnosis. So always take a moment and pause, don't carry on diagnosis just because you will find sometimes these cases. So the patient was hypertensive, she was obese and tall, she has masculine features, her skin have a lot of acne, acanthosis nigricans, hirsutism, her neck exam was normal, and she had breast under stage 5, pubic hair under stage 5, and on exam she has a clitoris that was 2 centimeters in length and 1 centimeter in width. Next slide. And of this one, the only thing I wanted to kind of show you is look at her morning 17-hydroxyprogesterone. We talk about being anything about 200 needs an endocrinologist, and sure enough, this was the case. Look at her testosterone. We talk about more than 55. Right methodology, right? So you trust this assay, really high free testosterone as well. The rest of the testing was normal. Next slide. And so before she came to endocrine, she had a Provera challenge that's primarily to assess the estrogen in the background, and then also be sure that there is the outlet has no obstructions. She did not bleed. She had some other testings, including karyotype, that confirmed she was 46XX. Next slide. And then when she came to us, we did a Cushing-Tropin stimulation test, and you can see the 17-hydroxyprogesterone did not rise as much, but you can see that the HEA is high, the testosterone is really high, the androstenedione is really high. This is very abnormal. You have to find where these androgens are coming. Next slide. So the provider that saw her before us wanted to be 100% sure it wasn't 21-hydroxylase gene defects, and did genetic testing. And when she came to us, of course, we did a Cushing assessment, and that came back normal. Next slide. So the next step in that kind of shortened list of the differential is adrenal ovarian tumors. And sure enough, she had ultrasound that showed that her right ovary had a complex cyst And that was about the size of the contralateral, the volume of the contralateral ovary. So it was at like a 9.6 mLs. When you do, and just with that ultrasound we look at the adrenals, and the adrenals appear normal. Ultrasound is usually not the best methodology for this, but that's kind of like how we started. And then we repeated the ultrasound to be sure that wasn't a corpus luteum, and we wanted to be sure that that was either still there, have resolved, and of course it was still there. With that, we moved to a CT pelvis and abdomen that found a tumor in her ovary. Next slide. She went to have that operated. She had a stereosate tumor not otherwise specified, and the ovarian changes were consistent with chronic anovulation. Next slide. And then over time, and this one I just show you how her testosterone remained low. She was old enough that on her surveillance, she graduated from our clinic as well. But the type of tumor she had could have metastasized just because of the nature of these type of tumors are quite aggressive. We were just very lucky that she did not. So that goes to say that you do not make a diagnosis in a patient that just started menses. Next slide. I think with this, I leave you with some of the reference. And next slide. And I thank you.